Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. Hello and welcome to another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. I'm here with Mette Willaume out of Denmark, correct?
Correct.
Awesome. Well, thank you so much for coming on the podcast. We sure appreciate you taking the time to talk with us. Why don't you just tell us a little bit about who you are and where you come from?
Of course. Thank you so much for the invitation. It's a great honor and fun to be part of. I'm living in Denmark, based in Copenhagen, but work approximately 4 kilometers south of here. I live in a small Copenhagen apartment, 72 square meters with my daughter and my boyfriend. And basically just loving my job and having a good time with my teenage girl and having a good time.
That's awesome. Now, did you do your training in Denmark, or is that where you're from originally?
Yes, it is. I have roots back to France, but I guess like in the States, here in Europe, we're a melting pot of different people traveling back and forth, and so definitely born and raised in Denmark.
And you, when you went to medical school, was that something that you knew that you wanted to do from a young age, or was that something that you developed that interest as you kind of went through your schooling?
Well, I certainly didn't know that I wanted to study medicine. I'm out of a long tradition of family of hand workers, of carpenters and bricklayers. So actually, I was the first one in my family to have to go to high school, and so I went on to university. Actually, I had biology in high school, and I found that was the one subject that I really liked, and everything else was just a bother. And then I thought I would study biology, but I was not very good at math or physics or chemistry, so it was a little bit of a blockage there. So actually, I started studying journalism, but then I just didn't. It didn't feel like it, and I dropped out, and I had a cleaning job and traveled to Vietnam and Central America, and then I just decided that I have to do this cell biology or medicine. I was so crazy about it, so I studied math and physics and chemistry for 1 year to go to med school, and then I got in, and then I never regret it. I loved my study and my job ever since I started. So I'm really fortunate to have it like that.
Do you think that whenever you went through, like you kind of took a path and then stepped away and came back, and obviously going through medical school, no matter where you do, it's hard. It's not an easy process. And do you think that stepping away and doing other things and trying to be happy doing other things changed your perspective when you were going through the actual medical school itself, maybe compared to some of your peers that might have just gone straight through?
Yeah, for sure, because this was really a choice of by heart, you can say. So even when it was really hard, sometimes I knew all along that this was my choice and this was what I really wanted. So nobody pushed me here, or I have no doctors or even nurses in my family to have been looking up to or getting help by. I worked in a nursing home when I was in high school for a spare time job, and that's where initially I actually thought I was going to be a nurse because I didn't think I could be a doctor, but then just developed, and I found out that I'm a little bit of a bossy person sometimes. So maybe the nursing thing was, I don't know, it was better as a doctor.
Yeah. Now, being the first person that had sought a higher degree or a professional degree in your family, was your family supportive of that, or did they have reservations? Because I know that there have been times that I've seen people that have gone through, like I have a great uncle who was an ophthalmologist, but nobody else in my family really sought any kind of professional degree. And so there wasn't just a ton of mentorship about how to make it through a process like that. A little bit of it was trial and error and kind of just taking that risk on yourself. Did you feel supported by your family? Not that they were not supportive, but were they pushing you for this type of work, or was it something that you really had to kind of venture out on your own and kind of blaze your own path?
Yeah, no, I was pretty much alone with this. Of course, they supported me in what I wanted, but they had like there was no one in my family had that background or interest or anything. Actually, my parents would dreamt of that I would become an actress or something. I think because that was their big dream. So it was. I don't know if I disappointed them by becoming a doctor, but I don't think so.
I mean, if you're going to fail at something, you failed well into being a world-known surgeon. I think that it's not as popular as being an actress, I suppose, but it works pretty well.
Yeah. So no, fun aside, of course they were very proud of me and supported me all the way. They didn't have any financial support possibilities, but as you may know, education here in Denmark is fortunately for free. So even though you haven't saved or coming from a poorer family, everyone can go to the university if they get the degrees to it and put the work in there. So that was really my luck to have the possibility to end up where I am right now. So I feel very fortunate.
Yeah, it's in the United States, we don't have that. My wife and I both grew up, my wife's a physician too. She's an OBGYN, but we both grew up without any, we'll just say we didn't have any extra means. I definitely didn't go hungry, but there was no, I was kind of paying my own way through scholarships. And so when we got into medical school, we went to a state school, so we weren't going like private or anything like that. So the cost was probably lower as going to an in-state medical school, but still, we graduated with, hundreds of thousands of dollars in medical school debt. And that definitely actually impacts the decision making, especially if you don't come from a background where there's because it requires a significant bet on yourself. And I think that sometimes we get into situations where if that path has never been blazed before, or if you don't have you don't know people that have been through and have seen the other side where things have worked out, then there's this fear that even taking that jump into a professional degree like that is sometimes limited because you don't want to do something, because if you fail, there's no way to ever pay off that debt, and it's something that is really concerning. So did you feel like you had a
Sorry.
No worries. Did you feel like you had the kind of freedom of choice as far as whenever you were going through medical school, that you could kind of choose what best suited you as opposed to considering the financial aspects of your future?
I don't understand what you mean.
Yeah, so whenever we came through, there are specialties over here that are not as well compensated as others. And so for fear of not being able to pay back the debt if you went into something that's a lower paying specialty, and whether the truth is that's probably not based in reality. It's probably more my fear that I had growing up, but it definitely influenced the decisions that I was making. And I just wondered if you felt any of that kind of pressure whenever you were going through a system where that was all paid for.
Yeah, no, it's when we graduate and when we decide which specialty we go into, we are all basically paid the same salary, even though you're going to internal medicine, surgery, whatever. It's of course there are some branches of surgery like orthopedic and plastic surgery where you have a bigger possibility to go out private, and in that way you can make more money, but most of us are paid by the government and we get the same salary, more or less. So
that's interesting because, I think that the United States, I'll say at least historically, and many would argue currently as well, is not very good at preventative health. And
we're not good at it either.
yeah, I was going to ask if you felt like you were that your system was better at like a preventative health aspect than we are.
Oh, I don't know. I think we may have better health education in public schools, but it is very bad here as well. But I guess due to the higher, like, low income wage here makes the poor people here in Denmark richer than many other places. So in that regard, we are, even though poorer people here are getting worse, like everywhere else, it's not as bad as it is many other places. So we are a little butter lucky, fortunate country here. That's for sure.
Yeah, we have a population of patients that we see that don't have any coverage and don't have the means to pay for any kind of medical care, and they usually go through the emergency department to access their medical care. And so many times people, like with a hernia, for example, will go in because they are curious or concerned about this hernia, but it's not in an emergent situation, and they get put back out sometimes onto the streets to seek charitable organizations or other pathways to try and gain access for care. What's the pathway for that population of patients in Denmark? Do they have access to care for hernias? Do you feel like that they delay the care for a basic hernia in many cases, or is that something they feel comfortable seeking out the care, just as obviously speaking in generalities?
Well, in Denmark, we are also so fortunate to have free healthcare. So every patient has a family doctor that can refer to the nearest public hospital where you will have basic hernia surgeries. So that's kind of quite easy for patients here. But we have a concern, and that is after COVID. We are still working on a huge amount of people that can't go to, because we can here in Denmark we have only very few private hospitals, and they are only allowed to do like basic stuff and uncomplicated stuff. So they can do inguinal hernias and benign, smaller skin resections and stuff like that. So that's very prioritized in the public system to have that, because we have to pay the private hospitals if we can't treat our patients within 30 to 60 days. And so the public hospital loses a lot of money. So that's prioritized now much more than it was before. And this is to the account of the people that are too sick and has too complex hernias to go out in the private. So there we have a long waiting list. I'm doing primarily abdominal wall reconstructions and complex hernia surgery, and I have a waiting list for over almost a year now for these patients, because we have 10 OR rooms with inguinal hernias per week that we have to do.
So you're doing like a straightforward inguinal hernia. If a patient presents to you and they don't have the means to go to one of the private facilities, a straightforward inguinal hernia that will, from the time that they seek an appointment with their primary care doctor to the time that they end up in the operating room, what's like a basic pathway or a time frame?
Well, I guess that will be around 2 to 4 months. So they go to their own doctor, who sends a referral to us, and we see the patient in the outpatient clinic and schedule them for surgery. And if we can't schedule them within 6 weeks, I think they have the possibility to seek a private hospital who have time slots before that. So that's secured in that way.
And the private hospital in that situation, if the public hospital is not able to intervene in a timely fashion, then the public system pays the private system to intervene sooner.
Yes.
So your year-long waiting list, is that more the more complex abdominal wall reconstructions?
Yes, that's the complex hernias and the patients who are too sick to go, because they can only take like healthy younger people in the private hospitals, because they have no ICU facilities and they have no beds, so they have to be daycare surgery, 100% sure.
Okay,
So
that's interesting.
Yeah.
Yeah, it's almost like, it's kind of funny there for a second. I was thinking in reverse. So really, the public hospital systems where all the complex work is done.
Yeah.
Okay.
Yeah.
Yeah, and so are you hernia only in your practice?
I am. After a long time, I've been doing. I've been a specialist for 5 years now, and I've been doing mainly upper GI since then. But yeah, recently, the past 1 year or so, I've been doing only hernias.
Is that something that you sought out, or was that something that just kind of, you were the one doing it and doing it well, and so then you just became that person?
No, I applied for the job in the hernia team at the facility where I'm working now, and I've been working here with Fredrik Hellstrand for 2.5 years, and so I definitely applied for the job. I did my thesis on optimizing outcomes after primary ventral hernia repairs, and so within that work, I got hooked up with a lot of hernia surgeons in Denmark, and got quite inspired by that. And so at some short point, I thought I was going to do colorectal, but I really hated, or that's a strong word, but I disliked doing all the works that was not in the OR room. So I quite fast quit that thought, and looked to all my good friends, and my very good friend through many years, Nadia Henriksen, was already in the top 10 of hernia surgeons in Europe. So I was very inspired by her as well, and then I just find it's a lot of good people who is in that branch of surgery. So that was really why I picked that. Then when I got to be a specialist after my training, I started working at Bispebjerg Hospital with Lars Nannestad Jørgensen, who is also a very famous hernia surgeon around the world, maybe the most famous, I don't know. And he was also like a very, very good friend and supporter, and that just made it so clear for me that this was the way to go. And I love hernias, and love the surgeries, and love the patients. It's I've been thinking about it, why I do love it so much, and I think it's like, I feel like when I go into the OR room, I feel like I'm the cleaner, like Harvey Keitel from Pulp Fiction. Mm-hmm. So I'm gonna clean up after other people's surgeries.
Yeah.
And I'm a quite organized and systematic person, so I really love that. Like, put it all back together in the right. Mm-hmm. It's weird, but I think that's why I do like it so much.
That's awesome. Now you were talking about your thesis. You did a PhD as well?
Yeah.
And what made you pursue the PhD? Was that something you expected to do, or was that just something that you felt? Were you already a practicing physician prior to pursuing your PhD, or was that part of your overall training?
Well, that's something that you apply for. That it is not mandatory in any ways, but I was advised to do so because it would give me better possibilities for jobs later on. And I've kind of, I think since I have the background that I have, I've always felt a little bit like I had to achieve or earn it a bit more. I always had that feeling that I would have to really prove my how to say, prove that I was good enough for being there, and so I think that was one of my many inspirations to do that. And yeah, it was worth it. Well worth it. And I was lucky to get the finance to do it for 2 years full time. And
what was the most surprising finding when you were doing your research? What was the outcome that you found that was the most shocking to you?
Well, that the results from open small primary ventral hernias was that bad. One of my works was I was using the data from the Danish Hernia database, of course, and then I contacted all patients who underwent primary ventral hernia surgery in a certain time period, and gave them questionnaires to whether or not they had chronic pain or any bothersome symptoms or suspicion of recurrence, and so if they got back to me and said they had any suspicion or any problems, I went to visit them and clinical investigation and CAT scans, and actually found that we knew that from another study also on incisional hernias, but we didn't know how it was on primary ventral hernias, and we found that people walking around with a clinical recurrence but not having a reoperation for recurrence was fourfold underestimation. Like, a lot of people was walking around with a recurrence that was more or less bothersome, but didn't go back to surgery to have a redo. Mm-hmm. And so it really surprised me that so many people actually had a recurrence for a small, uncomplex procedure. Mm-hmm. So there's a lot to improve. That was interesting, I think.
Did those patients just underwent a primary repair?
It was both primary and mesh repairs. So I investigated them in a stratified way, but it was like, of course, double up the recurrence risk if they didn't have a mesh. So
and what did you?
It actually led to that we changed the recommendations in Denmark that we say that basically all patients need a mesh, even though it's just a very small primary hernia. But if it's like very, very small, less than 1 centimeter, you can maybe suture it. But yeah, so that was pretty awesome.
Yeah, that was my next question, was how it changed your practice. And so even patients that are below that 1.5 cutoff and say they don't have, this is a primary repair, a primary umbilical, that below that 1.5 centimeter cutoff, and then they don't have a significant diastasis, you would mesh repair those as well?
Well, I have, after we got the robot, I've changed my practice in hernia surgery completely. Mm-hmm. And it has also, working more and more with it, we have found, of course, that it's not as much. We're so concerned about that defect size, and of course it matters. But I think other risk factors, as you mentioned, diastasis and obesity and smoking and diabetes is factors that we take into account now more than just looking at the defect as a sole factor. So it's more about, it's also the defect, but it's more about the other things if there are risk factors. So yes, I would always use a mesh in almost the only patients that I would consider, or that would, it's always a shared decision making. But I would always say to patients, like, we put in a mesh, then there's a lower risk of recurrence. But if you don't want a mesh, you should know that there's double the risk, and we can try it. But I would do it in younger, slim patients. But that's it, I guess.
So not to get too far into the weeds of the actual specifics, but this is fascinating to me. It's not very often that you get to talk to the person who actually did the research. And so if you go in, say, just as someone who's, a BMI of a very, very common patient for us, right? So a BMI 40, not a large diastasis, but significant visceral fat burden. Maybe they're not a smoker, they don't have diabetes yet, but they have like a 1.2 centimeter primary defect that's as they've become more obese has started to become symptomatic. What type? I'm assuming robotically you are closing the defect primarily, and then reinforcing with mesh. What size mesh are you using, and what positions your preferred positioning of the mesh?
Well, it's for the smaller defects, and certainly for all primary defects, I would go for a ventral tap, robotic ventral tap. In particular, this patient with a BMI of 40, even though there's no other risk factors, because we know that also from the Danish Hernia database that obesity and smoking is a huge risk factor for coming back for readmission and reoperation for wound complications. So we would definitely choose to do that as a minimal invasive fashion. I use a very standard polypropylene most of the times mesh, Optiline mesh, which is one of the standard meshes, and I would aim for we are talking so much about the mesh overlap, and it's so fun because we really don't know what we are going for, and it's even when we are discussing within the steering committee of the Danish Hernia database, we are not thinking about the same like size and levels of overlaps. We don't even agree on that in the steering committee. So it's I think it's a tough question, but I think I go for as big as possible. I mean, it's there are limits if you're doing a tap. So I think I usually aim for like 5 centimeter overlap on each side and cranial and caudal. So something like that.
Yeah, I think that's the question that I always that's a totally selfish question to ask, because that's the battle I always have in myself, is if I'm reinforcing like somebody who may have had a cholecystectomy in the past and they have this little 1 centimeter defect, and maybe I'm going in to do like a robotic inguinal, and they have this umbilical. And so to me, my thoughts are always, thought process is, if I do this all at the same time, from a satisfaction standpoint of them having to be out of work and it disrupting their lives and their recovery, despite the fact that I keep my patients out from a ventral hernia repair longer from activity than I would from an inguinal, it just makes sense to kind of combine those times away from their activities.
Sure.
But then, I always sit there going, I'm putting in a piece of mesh and it's such a small defect. Is it really, am I putting in too big of a piece of mesh? Is this overkill? And then, over here, we still have a lot of people that will do a primary and put in a disc. And of course, what I have found just from, observation, I don't have any data or anything, but just my anecdotal observation is that usually when people are doing a little open, even if they're putting it into the preperitoneal space of a disc of a sometime a dual layer mesh or something, or a coated mesh, that the overlap is not 5 centimeters. It's a much smaller disc of mesh than I would put in if I was doing a robotic repair. And so that's always been one of my kind of internal debates, and I always wonder if I'm doing the right thing. And I think that, just judging from your answer, it's that I probably fall pretty much in line with what you're talking about. And
I'm not sure we're gonna know until some years have passed, and then we will of course investigate it from the Danish database and hopefully get some answers. But I still think that overlap is it's difficult, but we have looked a little bit at it, and when we do robotic hernias, ventral hernias, we use significantly larger pieces of mesh for sure, because it's possible. And but is it a problem or not? Is it good or is it not? What are the downsides, and what are the I mean, I hope and I think that we will see in a few years, as people are adopting the robotic platform more and more here in Denmark. For now, we are only doing 5% of our ventral hernias on the robot, and almost no inguinals yet, but it will come, of course. But I think that we will see that the recurrence rate will drop. It just seems logical in my.
Are most people with the inguinal hernias in Denmark currently, are they still getting an open like Liechtenstein approach, or are they doing laparoscopic like TEP or TAPS?
No, we have within the steering committee, we looked at, we have the annual report and annual meetings, and we go through the data, and we also kind of point out new recommendations that we think how things should be approached. And because first of all, because we're such a small country, we only do lap tap for inguinals and Liechtenstein when we do it openly. So recently we decided, since it's in the EHS and AHS recommendations now, that we do all patients should undergo as their first line repair should be a laparoscopic tap. And so it's only for the recurrences that goes for Liechtenstein, or if it's a huge inguinal scrotal or something like that. So we are on a big course here, training all our young surgeons to do lap taps, but it's super fun and ongoing topic of debate. So that's interesting.
It's such an interesting, I think that something I've always admired about the Danish studies that come out and things is the fact that you guys do have such an amazing ability to track and to know, because I think we have a very piecemeal tracking of our own outcomes here in the United States. Some people, some institutions use databases extraordinarily well. I would say probably the majority of folks that are doing hernia surgery probably have a very limited understanding of their long-term outcomes, because just like you talked about the fact that even in a country that tracks outcomes as closely as Denmark does, that your findings from your PhD work were shocking just with the number of folks walking around. In the United States, we hear things like, well, they come in, they have an obvious hernia recurrence. Maybe they're there for something else. And you're like, well, your umbilical hernia is back. And they say, I already had that fixed.
Yeah.
And they don't even have they don't have that perception that, well, it was fixed. Of course it's not back because it was fixed.
Yeah.
And so that's a very interesting, it's a very interesting concept to me that even in a country that is as regimented on tracking outcomes as Denmark, that was surprising there. And it probably points to that in places where many people, are still are definitely not adhering to the EHS recommendations as far as the way we approach hernia surgery here in the United States for a large portion of surgeons. Probably not the people listening to this podcast, but a large portion of people that are still repairing hernias on a regular basis are probably not adhering to those types of recommendations, at least strictly. And so I suspect that our outcomes would be shocking if we had a tracking system that was as robust as the Danish system. So one thing, kind of shifting gears, one thing that you said earlier when you were talking, and it piqued my interest because you said something that I was like, that's exactly how I feel. You were talking about going to get a PhD, and you said that one of the reasons you sought a PhD was almost, maybe I misunderstood, but it was more to like legitimize yourself and show that you belonged. And whenever you said that, in my mind, I went, boy, there's not much. There are not many statements that are more true for me than that. In the fact that I'm always experiencing some level of imposter syndrome, where I'm sitting there going like, I don't know if I got to prove it over and over to myself that I'm, I guess, worthy of doing the work that I'm doing. Do you feel that type of feeling in your work? Is that what drove you to do what you've been doing?
Yeah, certainly. I've been feeling that most of the time. I think I've been really I didn't know about the imposter syndrome until a few years ago, but yeah, definitely I felt that way, and I think coming back from the background that I have, and that it was like I felt like in medical school I was just trying to do the same that everybody else did, because it was like they all know but I don't have a clue, and I
Yep.
just try to mirror what they do, and
Right.
and it was but I really, that's also why I fell in surgery, like because that was the first time I really felt in my medical student career that I really felt, this is home. This is something I know, because it's like hand workers. So that was more like a familiar thing for me, a familiar vibe for me.
Mm-hmm.
And so that's definitely where I felt I belonged. And yeah, then I just guess that I've always been very curious by nature. So I was like, oh, what is that PhD? And you have to do some mandatory research work during medical school. And I struggled a bit with it, and I had just difficulties finding my way around it. And then I just decided that, well, I have to put some dedicated time into this to really get to the bottom of it and understand it really, so it's not so difficult for me in the future. And yeah, definitely a certain amount of I really have to have it on paper that I'm as good as the others, I guess. It sounds stupid, but
no, that doesn't sound stupid at all. That sounds incredibly familiar is what that sounds like. And I think that I'm having just the brief amount of conversations that I've had, I think that many people experience that exact feeling.
Yeah.
I've constantly felt throughout my training that I was like, the student that, that at some level that I was a fraud, that at some level they just didn't know yet.
Yeah.
That like at some point I'm going to reach a level where everybody goes, actually, this guy doesn't know what he's doing at all. Yeah, I knew it the whole time.
Yeah,
this guy,
I knew it. Yeah.
Yeah,
I actually used to have a lot of nightmares about that. Like they would discover, like, oh no, she can't do it. She's not. Oh.
Yeah, 100%. I mean, I still do. I do. I have nightmares on a regular basis, and so, the other thing is, you talk about coming from people that work with their hands. I grew up on a farm. I'm a farm boy, and so one of the things that I found really refreshing about the farm was that I would work all day. And, after driving tractor for 14 or 16 hours, I'd get off at the end of the day and I'd be dog tired, but I'd look out and I could see a field, and with the tractors we had, I could plow around 120 acres in a day. And so I'd look out and I'd see 120 acres of plowed ground. And that gave me a sense of accomplishment that made me feel good. I like, you work all day and you can see the fruits of your labor. It's kind of funny because I think that is a level of instant gratification that does not lend itself well to long-term success, especially in our careers, when the gratification many times is even like decades in the future of what you're working towards. And so it was kind of counterintuitive. But when I got into surgery, I like the aspect of being able to fix something very similar to what you're talking about with hernias, get things back where they belong. Patient, it coughs a little bit as they're extubating them, and you don't see the hernia explode back. Hopefully. I think I've had one do that before, big pop, and I'm back in there, 30 minutes later. But I think that those types of situations coming from the background, and I think that's the other thing you said that I was like, man, that makes a lot, that I relate completely to that, is that from our background, whenever you don't come from a background of like a high professional degrees and things like that, it's always this kind of feeling that everybody else knows what they're doing and you somehow don't. Yeah. So one place where that really affects me deeply is if I have a complication. Because if I have a complication, to me, the mental toll, I think at times is much higher than some of my colleagues. And I think that I'm not at all saying that they don't take it seriously. They absolutely do. And it affects them in their own way. And that's not a criticism at all. But what I'm saying, I guess, is to me, every time I have a complication, it is obviously first and foremost about the patient. And that's first, second, and third. But it also affects me deeply because it serves as evidence to this bias that I have that somehow I'm living as an imposter around all these other people that are so qualified, and I have immense respect for all my colleagues that I don't necessarily have for myself. How do you handle complications, and do you think that affects you? Do you think that your background and that feeling that you had over the course of time and your training, does that affect you when you're experiencing a complication currently?
Yeah, for sure. It's devastating, and it's groundbreaking, and it's such a horrible thing to. I mean, the reason why you want to become a doctor is that you want to do something good. You want to help people. You want to make their lives better. Mm-hmm. So if you have a complication and well, maybe not a superficial surgical side wound infection or something like that, I can deal with that. Mm-hmm. But if you have a more serious complication, I really struggle with that. But I think that's really one of the things that I love so much about our hernia society, is that it has been the recent years. It has been a very, very positive trend that even the best of the best of the best, like the hernia gods that we know and that we look up to, they share all their worst complications, and they tell about it, and they show us that it happens to all of us because shit happens and we are just humans, and so I'm trying to really adopt that more, like but of course it is horrible, and I really want to, like, when I do have it, I just, of course, fix it as soon as possible. We can as soon as we discover it, and I can have patients that have had complications much more in control, and they have my private number, and I ask them to call if there's anything that is not going well, and I really try to make sure that they feel safe and comfortable, and then I really, instead of, I've been beating myself up a whole lot, and I've discovered that that's not very productive. Mm-hmm. So I'm trying to build a more productive way of handling it, where I am trying to look at it as a learning situation, like, and then share it with my colleagues and my trainees, and like, this was happened, why did it happen, what could I have done instead, and how could we have prevented it, and I think that's what we have to use our complications in that regard, instead of just banging our heads in the wall as I used to do, and feel worse and feel like a bad surgeon and all that, and trying to adopt that in my trainees as well. I'm trying to tell them, like, when you make a mistake, then celebrate. And they look at me like, huh? What? Why? And it's because you learn something, and you really learn something from your mistakes, more than when everything goes well, right?
Right.
So that's what I'm trying to do instead. Yeah.
Yeah, I think I've very much tried to do the same. I found a few pitfalls whenever I started doing that. I started doing that fairly early in my practice. I felt like as I came through my training, that the people that I looked up to, in my perception, they were on such a different level that they didn't have complications, or when they did, it didn't affect them the same way. And I don't think that it didn't affect them. I think that was something that I just wasn't privy to. I didn't see that. We rarely call our trainees and say, like, I'm struggling with this complication. We call our colleagues or our family, or we don't speak to anyone at all. And we just kind of swallow it, and we suffer in silence, and it eats us alive. So I tried to be more honest with my trainees early on. The problem with that is when you don't have a reputation to stand on, or you don't have a volume of good outcomes, especially if it's early in your practice and you have one of those complications, because they can strike at any moment. And when they come, they seem to come in groups, and it's the most humbling few weeks of your practice every time. And then eventually you start to like, hey, maybe I'm not so bad. And then boom, here it comes again. Nope,
Yeah. Yeah.
still mortal.
Keeps you
And
humble.
yeah, yeah, and I think that, and so I tried to share that with some of my trainees, but it's an interesting thing because if other colleagues aren't sharing,
Yeah. Yeah.
then it makes you look like you're just really, it can really affect your reputation in a negative way when you're really trying to do something that you think will be helpful and beneficial long term. Because I think that whenever, I can think of a few times when I know that people experience their complications pretty personally, and I remember those pretty specifically. I think it's beneficial because when you're out, there is nothing more isolating, nothing you never ever will feel more alone in the operating room when you're cutting through your own closure. You're cutting out stitches or you're removing staples. I mean, there is like, you could be in a room of 20 people, but you might as well be, on the top of Everest all by yourself. And if you have that one moment where you go like, hey, I remember Dr. So-and-so, they told me about this. I think that helps ratchet it down. And really, I mean, that is really one of the reasons that I think the discussion that we're having right now is so important. Because, like I've said before, you're immensely respected by your colleagues. And there are people out there that don't have that I think would be surprised to hear that it affects you as much as it does. But you're not abnormal. In fact, you're probably more normal than the people that it doesn't affect. And in some of these conversations with people that I immensely respect, they say things like, if it ever gets to a point that it doesn't affect you, that should really raise a lot of your alarms should be going off.
That is a problem. That's the worst thing that can happen. If it doesn't affect you, or you don't care, or you just say, shit happens, and then there's something wrong, I think. And because then you've grown cold, or I mean, that's a problem. That's a real problem.
Yeah, it's tough. It's tough for me. I 100% believe in trying to learn from other people's complications so that everybody doesn't have to repeat the same mistake. Yeah. On the flip side of that, whenever you take your outcomes so personally because you may not have the ability to separate your performance from your own self-worth internally, presenting your complications is not it's not an educational activity. It is like a soul-bearing activity that can absolutely crush you. And there's no, we're surgeons. Many of us have strong personalities. Many of us have very strong opinions. I'm not I'm not immune to that either. There's no better surgeon than the person that's commenting on someone else's complication after they have the whole story. I would have done this. Yeah. Well, I'm sure you would have, knowing how it turned out. Yeah. Do you feel like one thing that when you were talking about the Danish database, is that a stressful thing for you, having all of your outcomes scrutinized to that level? Or is that something that you find comfort in, that transparency and the ability to, one, that you're seeing everybody's outcomes, and like you talked about, realizing that even the best of the best have their own issues? Like, how does that hit you when you're having your outcomes tracked so specifically whenever your complications are so deeply personal?
Well, we can't track it back to one person. Well, we could, but it's like the annual report that we get and that we make are more based on a hospital department level. So it will be you and your colleagues, how you're performing as a team. So it's in that regard, it's not that personal. But of course, it would also be a little bit interesting. But you can track that on a personal level. But yeah, it can be both, of course, like a troublesome thing, but also, most of the times it's you can see it's okay. So we are on the level as the other hospitals that deal with the same kind of patients that we do, because of course there are differences to whether you're working at a hospital in the rich region or in a region where patients are from lower income and lower physical health, because there are more, they have more complications, readmissions. We know that. But yeah, it's not that big of a problem to that regard. I don't think so.
Yeah, that's all. That's whatever you were talking about. That I felt my heart rate like rise, just like going, oh boy, because like I said, if it's something that you have a hard time separating your outcomes from your own self-worth, which many people who I think the other thing that we may suffer from in the field is that you have to be consistently successful to reach the level of being a surgeon in general, much less somebody that's high up in the field of surgery. The pyramid, the numbers keep getting, tighter. And so, whenever I was in medical school, I would be expressing to old friends or from the past or my family, oh man, I'm really stressed about this test. And they go, you always do well. I'm like, well, yeah, but so did everybody else in the class. At some point there's at some point somebody has to get last, and eventually you get to a point where, and so, it's just really, it's such a humbling thing to have to go through it, because you may get into your practice before you really feel failure. Like many times people are so successful so consistently to get to the level they are. And then you get into practice and maybe you have a run of complications, and it's even more devastating for someone who has never been out in the real world, like your experience of stepping away from your studies and being abroad and doing and experiencing life and gaining that perspective and then coming back into the field. I suspect that you have a little bit of a wider reference on who you are and life outside of medicine that allows you at least a little bit of distance, be able to distance yourself from the situation and understand that it's all part of the bigger picture. Do you feel like that lent itself to you being able to handle those situations better?
Well, not really, because I'm really devastated every time there is a complication or I'm causing a patient trouble, because we all really want to just do good and help. So it's really, really, really troublesome to have complications. But yeah, it's I think it's important to have good colleagues who you can talk to about it, and who I'm at my workplace now. In my team, we have such a positive vibe, and we help each other, and there's not much of a look what you did, and we don't, there's no picking on one another, and there's no competition in that regard. So it's amazing, and it's really helping you a lot achieving better, because I think that in the past I was so afraid of making mistakes, of making complications or problems, that I would lose flow, and I would then, if you're not in flow, you're not operating as good, you're not as good as a surgeon. So you have to be. So I think one of the things that are one of my major things that I really think are so important that we should talk much more about is safety, like psychological safety, to achieve and to learn and to be able to make mistakes, because we all do, and we can't prevent it. We can prevent many things, but we can't prevent anyone from making mistakes. It's gonna happen. But to have that psychological safety to say, like, shit happens, but then I know my team has my back, and we help each other and we back each other up, and it's like back on the horse, and then you'll do the next repair again because you had a bad experience, and that's how we work, and it's amazing. It's amazing what it can do, and it has really moved my how to say, my joy in my workplace so much, and flipped it.
How do you create a culture like that? I mean, it sounds like you guys are very supportive of one another. Those types of cultures, obviously there are aspects of personalities and people involved, but I would suspect that creating a culture like that is very intentional. And so, do you have any recommendations on how to foster that kind of a culture within a group?
Well, I think because I have I during my training I didn't encounter really any problems, but at one time at one job I kind of encountered that culture where you were picking on each other and talking behind each other's backs, and it was like the worst time of my life as a doctor or a surgeon, and I really felt how it degraded me as a person and as a surgeon, because when you're every day you're afraid of what people are going to think about what you do, and you have to make like 5 speeches to defend what you did 5 o'clock in the morning on a call or something like that. It's so counterproductive because it creates that fear of making something that somebody else thinks was bad or not good enough or something. So I think it's I really learned so much from that experience, and that's why I'm so how to say concerned or so deeply invested in that psychological safety, because then I came to my current workplace, and it was like completely opposite. It was just supportive and positive, and that created the room for me to get back on track, and then I really got, it was so obvious for me the two differences, and then I really started doing that intentionally and building up, like putting that into our team deliberately, and so it just went on as a very positive cycle, and it has really built every one of us up and just increased our work joy a whole lot. So
Is it a structured? Do you have like a structure to it? Like, for instance, I know that in our practice, if we have a really tough case or a tough complication, many times we don't scrub with other attendings. We're usually the only attending in the case.
Yeah.
I know other places they may have two attendings, one as an assistant or what have you, but not in our system at least. And so, but if you have one of those, many times we'll have two attendings scrub. And I think that I'm a big believer in that, for one, and it really does go back to your idea of psychological safety, in the fact that whenever you're struggling personally with the difficulties of dealing with that secondary trauma of the outcome, I think that my fear is always that there will be a lack of objective judgment, that you can want something so badly to be okay that maybe it affects what the decision making at the time, or it's a human nature thing. And I don't have exact examples, but a human nature thing to try to explain away a complication because you're so concerned it's happened, or you're so concerned about what that means if it happens, that you lose objectivity. And so do you feel, is there a structured way that your group or that you personally would approach that to try and maintain that objectivity, create that psychological safety, create that culture of support, not only to make sure that the patient has their best outcome possible, which is, again, first and foremost, but also to support us as human beings and not just machines that are surgeons?
Well, it's not structured. It's not that deliberate, or how to say, but it's more like if you can see one of your colleagues is struggling, then be open about it, talk about it, and especially when I have complications, when I've been struggling, when I'm feeling bad about something that happened or did, then I force myself to tell my colleagues about it, so they know that it happened and how I feel, and then they also feel I actually experienced, like, then they tell me of some bad experience they had or some bad complication they had, and it's just a positive reinforcement, I think, in that regard. But of course, there are some people that are completely oblivious to that. I don't know. There are some people that I mean, we also must see that we have different personalities and different chemistries, and we work better with some people than others, and I definitely work best with people who are positive and engaging and stuff like that. So it really didn't work for me with the other culture I experienced, because it really got me down completely. But yeah, so that has actually been my main thing, just avoiding that negative back talking, talking behind people's backs or criticizing. Just try to be objective. It's like, I don't know, sometimes I think about it like if you went to a marriage therapy or something, you have to have it like stay on your own side of the track of the field, and tell how you feel instead of just pointing fingers at others. That's the most immature thing you can do. Not looking at yourself and see what you bring to the field, but always pointing fingers and criticizing others. That's a really immature and unintelligent way of approaching things, I think. So I think, but it also comes from fear, because people who are afraid, they have to pick on others, and that's it goes back to schoolyard, and it's just immaturity.
Yeah, I think a lot of it's based out of a little bit of lack of self-awareness. We're a cross culture of society. Surgeons are not just a one size fits all, and we have obviously different personalities. We have different coping mechanisms. People are at different levels of their own development as far as them as a human being. I think that something you said that I couldn't agree with more. I think that the flow of not only the surgery, but the flow of a practice and the patient care that you receive, I think it's an underestimated component of that, of how well the team is functioning, and not just the team in the operating room, but the team as a whole. The culture that these people are practicing in, the ability to make a mistake and it not end your career. I'm not talking about people who are having problem after problem after problem, and it's obviously a judgment error or a technical skills error or what have you. I mean, that there are people that fall within that. And I'm not saying that, we should ignore those types of situations, but giving people latitude to be human is incredibly important, because like you said, one of the biggest things that I've struggled with whenever I have a complication is the next case, right? So you get in there and, if you've tracked my OR times, the case I have after a complication is always longer, always.
Yeah.
And it's because double, triple checking every single step, trying to make sure that everything, that I don't repeat the same issue. At some level, that loses its protective benefit and becomes detrimental to the flow of the case, which can be detrimental to the outcomes, which can be detrimental to the decision making. Pursuing perfection whenever good or great is more than enough, but that extra pursuit of perfection can sometimes lead to unintended consequences. Those are all very human reactions to the stress of what we do. It's not a secret that physicians have very high rates of certain mental illnesses and also substance use, and our suicide rates are higher than the average populations, at least in the United States. And I think that it all goes back to feeling supported in an otherwise extraordinarily stressful field. In some part, there are many components to all of that. That's not meant to be an oversimplification, but I think one of the components is how supported you feel when things aren't going correctly in your job, and how you are able to handle that. And a lot of that is based on your own internal issues, but also the environment that you're functioning in. And so I think that hearing perspective like yours, I think is invaluable. So, and I know many times it's, at least for me, it's like not easy to share. It's not a comfortable conversation to have, but I think it's a necessary one. Do you think Shifting gears slightly again. You talked about having a teenage daughter. I have a currently 5-year-old daughter. She acts like a teenager, which is terrifying to me. She's a very strong-willed little girl, which is I definitely am 100% supportive of, because I think that's going to serve her well in the future.
Yeah, for sure.
Coming from your background, I'll share with you my fears, and I'd be interested to hear your thoughts. My wife and I both came from a situation where we felt like there was no backup plan. Where if we failed in our pursuit, we didn't have a plan B. It was always plan A, succeed or die kind of attitude.
Yeah.
And so that led us to be, extraordinarily driven. And when we've reached the level of success that we are, our children beautifully are able to live a life that we never experienced growing up, that we worked for 30 years to get to, and they were born into it. We have struggled with concerns of how do you replicate that level of drive? Does it require you to experience it personally to be able to get that drive, or is the expectation of success inherent if that's all you know? Have you, as a parent, have you ever thought about that aspect of parenting, and if so, how has that affected how you've been a parent to your daughter?
Well, it may sound a little, I don't know, softy or something. I don't know, but I in the beginning I thought that she was almost like me. She looked like me, or she was acting like me, because your kids, they get to be a lot like you, mm-hmm. whether it's due to genetics or environment. But I kind of, didn't wish it was not like I would, of course, be supportive of whatever she wants to do, but I kind of wished that she wouldn't go for a career job, actually. But I was very sure that whether she would choose one or the other, I would be supportive. And I'm quite sure she's not going to be a doctor and a surgeon. But yeah, I think you're right in that. I think that drivenness, or that eager to achieve, that overachiever thing that many of us have going on, it comes from some kind of a survival mode. It's a way of survival, and so in that regard, I just hope that my daughter feels so stress-free. I don't know if you can say that she can choose whatever she wants to do in her life. And I mean, if she's gonna want to be an actress, or a child caretaker, or sitting in the supermarket, I hope that she's just gonna do that makes her happy, and have that life that's gonna make her happy. And so we have a lot of discussion about that priorities and families. She wants to have a lot of horses and a lot of children, so we've been talking that's not compatible with a high career job and stuff like that, and so try not to put too much opinions on her, so she can make the choices herself, because we live in Denmark and there are many possibilities here, and so we don't have to be so concerned about making money and making enough money to have things to go by and stuff like that. So we're very fortunate here.
Yeah, I think that you probably hit on the main point, that I think there's a level of probably not a good thing how driven, that my wife and I are. And so it's been something I've had to work on. Like my son, even in T-ball, I'm just like, you're not giving 100% effort. And he's just like, it's T-ball, and I'm like, fair. There's nothing like the opinion of a child to put life back into perspective. Exactly. It's like it's the mirror of, they will mirror back to you your best and your worst qualities. And they also have the ability to be incredibly brutally honest. My wife was at work the other day, and she works night shifts some still. And so she was at work delivering babies. And so I was home with the kids, and we went through the bedtime routine, and I laid down with my daughter in bed to have her go to sleep. And she like snuggles up to me, and I said, her name's Ellie. I said, Ellie, I really enjoy getting to snuggle with you. And she goes, yep, I like snuggling with you too, Dad. She goes, I just close my eyes and pretend that you're mama. Thanks.
That's so cute.
Yeah. I was like, oh, good.
That's fun. Okay, thank you. Yeah, second choice, always. Great.
From the mouth of babes.
Brutal honesty, and it's honesty. Lovely. I mean, yeah.
Maybe actually she might be a surgeon if you think about it. Brutally honest. There you go. She's
it's
well on her way.
It's definitely on the list of...
Yeah, she loves. She wants to take care of babies. That's her thing. She loves being a doctor to her baby dolls and all that stuff, and that's what that's one of her big things. My son, on the other hand, people will ask, do you want to be a doctor like your parents? And he looks at them, and the best one is the last time they asked him, he looked at me, he goes, no, he goes, sometimes they go to work and we don't see them for days.
Yeah.
We're like,
exactly. Okay.
And that one too, you're like, oh, right in the heart, Oh, yeah. Sorry, buddy.
Yeah.
Well, one thing that we do at the end of every podcast episode is our hernia hot take. You get the opportunity to kind of give your thoughts on hernia surgery or an unpopular opinion. It's just really your chance to kind of give a thought or a take that you want out there. So this is your opportunity for your hernia hot take.
Ooh, that's a difficult one, but as I know you have had robots in the States for many more years, and it's much more spread out than it is here in Europe. So it's kind of a newbie here, but I really think that has and is changing our practice in hernia surgery or in surgery in general, because you can achieve so much more. And I'm just, every time I'm in that console, it just amazes me how much better tissue handling and anatomical structures that you can see. So it just makes me performing much better. So I think it's such a great tool and such a kind of life-changing tool in hernia surgery. Hopefully for the patients. I think also that it's wonderful how the communities and the societies are gathering and getting more and more popular. Because when I got into hernia surgery, it wasn't that big and it wasn't that specialized. But now we are in Denmark working on getting it as a subspecialty, as its own subspecialty within surgery. And I think it's due to so many engaged people who work so hard for making a community of better performing surgeons, better education, better knowledge, and that's just amazing. And I think that is what we should work on in the future, to just keep on that track. And yeah.
Well, I certainly appreciate you coming on the podcast. It's been a fantastic conversation. I've very much enjoyed it. And hopefully in the future we can have you on to have more discussion, because there's so many more things I would love to discuss with you. But again, thank you so much for coming on, and we look forward to talking to you again in the future.
Thank you, Luke. It was a pleasure to be a part of, and I'm very honored to be invited.
Thank you.
Very nice talking to you. It was very, very pleasurable.
Great. Well, this concludes another episode of the Hernia Gods Podcast. I'm your memorable host, Luke, and we'll be signing off. Thank you.